Welcome back to the deep dive. Today we are taking on a foundational, formidable, and fascinating subject. Chapter 40, The Knee from Bailey and Love's Short Practice of Surgery.
And this isn't just a quick review. This is a deep dive specifically engineered for precision. Our mission is to really distill the core knowledge of the knee joint.
Which is such a complex structure,
Yeah.
so prone to injury and, degeneration.
Exactly. The goal here is clarity, easy recall, and immediate clinical application for you, the listener. We're synthesizing the anatomy, the critical biomechanics, the whole spectrum of pathologies, and the advanced principles of surgical management.
That is a massive undertaking because the knee is, well, it's not simple. It's one of those structures that looks deceptively simple from the outside, but anatomically and kinematically, it's just a high-stress puzzle. Okay, let's unpack this, starting with the essential foundation. What is the knee joint?
Fundamentally, the source defines it as a synovial hinge joint, but that definition, I think, it almost undersells its complexity. It is, in fact, an assembly of three distinct articulations operating in concert.
Three joints in one, basically.
That's a good way to put it. You have the two condyloid tibiofemoral joints, and then the single-cellar or saddle-shaped patellofemoral joint, and that inherent geometric mismatch, the round femoral condyles, sitting on the relatively flat tibial plateau, that's the very source of its mechanical vulnerability.
So if the geometry is inherently unstable, the joint's function, our ability to stand, walk, absorb impact, it must be entirely dependent on extrinsic supports. How does the body compensate for this fundamental instability?
It compensates through a precise, balanced interplay of static and dynamic stabilizers. The static stabilizers are the passive structures, providing immediate resistance.
So the non-muscular parts.
Exactly. The strong fibrous joint capsule, the menisci acting as wedges, and the primary restraints, the crucial cruciate and collateral ligaments.
And the dynamic stabilizers are, of course, the muscle power.
Precisely. The dynamic stabilizers are the muscular engines that control, guide, and protect the joint during motion. Primarily, that's the powerful quadriceps group anteriorly and the hamstring group posteriorly. They are essential secondary stabilizers, especially during high-demand activities, like pivoting or rapid deceleration. The learning objective here is that perfect knee function requires both systems to be absolutely optimized.
Okay, moving into part one, let's start with those structures that bridge that anatomical mismatch. The menisci. They are these crescent-shaped fibrocartilaginous structures, the medial and the lateral. We know they cushion, but what is their mechanical contribution to stability?
Oh, their role is vital and multifaceted. It extends far beyond simple cushioning. Firstly, they deepen the shallow tibial fossa, which effectively increases the contact surface area between the femur and tibia by up to 50%.
50%, wow.
Which is essential for dissipating load. Secondly, and critically, they contribute significantly to anteroposterior stability, helping the cruciates resist that forward and backward translation.
Now, here is where the clinical reality hits the anatomy. The source highlights a major statistical difference between the two menisci.
Indeed, and it's a big one. Medial meniscal tears are approximately 3 times more common than lateral tears.
3 times.
And this is directly linked to anatomy and mobility. The medial meniscus is relatively fixed because its deep layer is tethered directly to the medial collateral ligament, the MCL, and the joint capsule. The lateral meniscus, however, is far more mobile.
So it can get out of the way.
It can get out of the way. It's less prone to being trapped and torn during a twisting injury.
That difference in fixation is a really key concept. But let's get into the mechanism of failure, this concept of hoop stresses. I often hear this mentioned in surgery, but what does it actually mean and why is its disruption so catastrophic for the joint?
Okay, think of the meniscus like a hoop or the rim of a barrel. When the load, your body weight, comes down through the femur, the menisci transform that vertical compressive force into horizontal circumferential tension. That's the hoop stress. The collagen fibers run around the perimeter, resisting that outward pressure. This is the exact mechanism that protects the articular cartilage.
So if the hoop stress fails, the protective mechanism is just lost.
Precisely. If you sustain a radial tear that runs perpendicular to those circumferential fibers, or if the meniscal root detaches, you break the chain. The meniscus sags outward under load, the force is no longer transmitted circumferentially, and all that force is suddenly concentrated onto a tiny area of the articular cartilage.
And that's what leads to arthritis.
The source emphasizes that damage that disturbs this hoop stress, like a large meniscectomy or a root disruption, leads to rapid degenerative change and the quick onset of osteoarthritis. Preserving that circumferential integrity is absolutely paramount for joint longevity.
Let's transition from those wedges to the major cables, the collateral ligaments, which prevent side-to-side motion. Let's start with the one most likely to heal well.
That would be the medial collateral ligament, the MCL. It is the primary restraint to valgus stress, meaning it stops the knee from collapsing inward. Structurally, it's broad and flat, and we must remember it has those two layers.
Oh, that's right.
The superficial layer, which is the main stabilizing cord, and the deep layer, which is the one intimately attached to the medial meniscus.
And the clinical pearl is its healing potential?
Yes, despite being frequently injured in contact sports, the MCL has an excellent capacity for healing with conservative management. Its broad structure and its relative proximity to vascularized tissue contribute to this successful recovery, often allowing us to manage isolated MCL injuries without surgical intervention.
Now contrast that with the other side, the lateral collateral ligament, the LCL.
The LCL is structurally very different. It's cord-like, much thinner, and functions as the primary restraint to varus stress, so it prevents the knee from bowing outward.
And it's not working alone.
Not at all. Crucially, the LCL is not an isolated structure. It's a key component of the intricate posterolateral corner complex, which also includes the polydius tendon, the biceps femoris, and the iliotibial band.
Why does that complexity matter so much for healing?
Because of the high-tension environment of that posterolateral corner and its cord-like structure, Grade 3 LCL injuries are far less likely to heal conservatively. They often require surgical reconstruction to restore stability to that entire complex. If you miss an injury to the LCL or the associated structures, the stability risk is just very high.
Okay, moving to the central pillars, the cruciates, the ACL, and PCL. We can't talk about them as single static ropes. They are bundles, and that detail is key to understanding the knee's function at every degree of flexion.
Absolutely. The anterior cruciate ligament, the ACL, has two functional bundles: the larger anteromedial bundle and the smaller posterolateral bundle. The anteromedial bundle is the one that is tight and provides restraint when the knee's in flexion.
When it's back.
Right. Conversely, the posterolateral bundle is the one that's tightest when the knee is in extension, providing rotational stability.
And their primary job is?
To prevent the anterior translation of the tibia on the femur, especially during deceleration.
The PCL flips that dynamic entirely, preventing the tibia from moving too far back.
Correct. The posterior cruciate ligament, or PCL, is thicker and stronger than the ACL. It also has two bundles: the larger anterolateral bundle, which is tight in flexion, and the smaller posteromedial bundle, which is tight in extension.
So the same principle applies, just different names?
Exactly. The principle holds. Different parts of the ligament tighten depending on whether the knee is bent or straight, ensuring continuous dynamic stability across the entire range of motion.
Here is a high-interest point that puts the trauma scale into perspective. We know single ligament tears are common in sport, but the source emphasizes a critical clinical difference when multiple ligaments are involved.
Yes. When we talk about multiple ligament injuries, so disruption of two or more of the four major ligaments, we're often moving out of the realm of isolated sporting incidents and into high-energy trauma scenarios,
Things like car crashes.
frequently associated with massive deceleration, like car crashes or falls from height.
And what's the immediate danger of that specific high-energy mechanism?
Joint dislocation. When the knee is truly dislocated, you have an extreme orthopedic emergency. The two greatest threats are damage to the popliteal artery, which can lead to limb ischemia and loss, and injury to the peroneal nerve, which causes foot drop. This demands immediate attention, often before a full assessment, to restore the blood supply and reduce the joint.
Okay, let's step back from injury and discuss movement itself, the kinematics. It's not just a perfect hinge.
No, not at all. Knee motion primarily occurs in the sagittal plane, typically spanning from about 5 degrees of hyperextension to 135 degrees of flexion. What is fascinating is how this movement is achieved. During flexion, there is a combination of femoral rolling and femoral sliding on the tibia.
Rolling and sliding.
You start with rolling, but if the femur just kept rolling, it would roll right off the back of the tibia.
So sliding has to kick in to keep the joint centered.
Exactly. But it's even more complex due to the screw-home mechanism. As the knee moves from flexion into terminal extension, the tibia is forced into an external rotation.
And why does that happen?
Because the medial femoral condyle is longer than the lateral condyle. Since the lateral condyle finishes its movement first, the medial condyle must travel further, forcing the tibia to rotate externally to lock the knee into place for stable standing. This is why rotation increases as flexion increases.
Here's where it gets really interesting. The patella. That small bone in the front, the keystone of the extensor mechanism. If we think of physics, what is its mechanical contribution that makes it so indispensable?
Its function is pure mechanical leverage enhancement. The patella acts as a sophisticated anatomical pulley for the quadriceps tendon. By holding the tendon away from the axis of rotation, increasing the lever arm, it drastically increases the torque and efficiency of the quadriceps.
So without it, you lose a lot of power.
A huge amount. Removing the patella or damaging its ability to track correctly severely compromises quadriceps power.
And the load it handles is staggering. I mean, we are talking about massive, unbelievable stress placed on this one small bone.
It is truly extreme. The patella has the thickest articular cartilage in the entire body for a reason. It is structurally designed to withstand compressive loads up to 20 times body weight when jumping.
20 times. Just let that sink in.
Just stop and think about that magnitude of force, 20 times your body weight, being transmitted through the patellofemoral joint during explosive activity. This phenomenal load explains why minor issues like abnormal tracking or slight alignment problems quickly manifest as significant chronic patellofemoral pain.
Let's connect this demanding geometry to the operating room. We need a fundamental grasp of the lower limb axis for something like a total knee replacement. The source differentiates between the anatomical and mechanical axes.
And this is the blueprint for alignment. The anatomical axis is the line running through the center of the medullary canal of the femur or tibia. The mechanical axis, however, is the functional weight-bearing line.
Where the force actually goes.
That's right. It must run straight from the center of the femoral head, so the hip joint, through the exact center of the intercondylar notch of the knee, down to the center of the ankle joint.
For the tibia, these two lines are often coincidental. They line up pretty well, but for the femur, they diverge. Why the divergence?
This is due entirely to the offset of the proximal femur, the angle of the femoral neck and shaft relative to the pelvis. This offset means the anatomical axis of the femur is laterally displaced compared to the mechanical axis. The standard angle of divergence between these two lines is consistently cited as 5 to 7 degrees.
And that angle, that 5 to 7 degrees, becomes crucial for the surgeon performing a TKR.
Absolutely vital. That 5 to 7 degree angle is what the source calls the valgus cut angle. When performing a TKR, the surgeon traditionally uses an intramedullary guide placed down the central canal of the femur, so along the anatomical axis,
Okay.
to ensure the final cut of the bone is perpendicular to the mechanical axis, the true weight-bearing line. The guide must be set to this 5 to 7 degree valgus cut angle.
So if the surgeon used a 0-degree cut, they would be aligning the new components along the anatomical axis, not the mechanical axis.
Exactly, and the consequences of that malalignment are severe. If you introduce a geometric error, you instantly shift the load onto one area of the new polyethylene-bearing surface. This leads to dramatically increased stress, accelerated component wear, and a much higher risk of aseptic loosening and premature failure of the joint replacement. Understanding the mechanical axis is the absolute foundation of successful TKR surgery.
That detailed structural foundation leads us perfectly into part 2, the conditions that affect the joint. Let's start with the most common pathology requiring arthroscopy, meniscal tears. What are the key patterns the source highlights?
Meniscal tears are classified by their geometry and location. The patterns include circumferential, like a bucket handle tear, radial, which runs from the center outward, flap tears, or chronic degenerate tears. The location dictates the blood supply and, hence the repairability.
MRI is the investigation of choice for definition, but the critical decision, especially in acute sports injuries, is repair versus debridement. What are the strict criteria for favoring a repair?
Well, the clinical goal is always preservation, if possible, because of that critical hoop stress we just discussed. We favor repair for a very specific subset of patients.
Who are they?
They must be young, presenting early, have a simple tear configuration like a stable bucket handle tear, and most importantly, the tear must be located in the vascular outer third, the red zone.
Because that's where the blood is.
That outer third has a blood supply and a chance to heal if you fix it securely.
So for an older patient, or a tear in the avascular inner 2/3,
those are primarily managed conservatively, unless they cause persistent, severe mechanical symptoms like locking or catching. Degenerate tears, often seen in the context of early arthritis, are usually treated with stable debridement, just trimming the unstable flap back to a healthy rim if non-operative measures fail. The key differentiator is always the vascularity.
Shifting focus now to the most common serious ligament injury, the anterior cruciate ligament or ACL rupture.
This is the defining injury of pivoting sports. The mechanism is usually non-contact. It's a twist, landing awkwardly, or a rapid deceleration. Clinically, it's classic. The patient reports an audible pop at the time of injury,
That pop is key.
followed by immediate, significant hemarthrosis joint swelling due to blood, making it very difficult to bear weight.
The source also touches on risk factors, particularly the higher incidence in female athletes. Why is this demographic specificity highlighted?
It's multifactorial. Studies point to anatomical differences like having smaller femoral notches and smaller ligaments overall, but the biomechanical differences are key.
How so?
Landing mechanics often involve less knee and hip flexion and more valgus collapse, which puts higher strain on the ACL during those crucial moments of deceleration. Hormonal factors and generalized ligamentous laxity are also thought to contribute to this increased risk.
How does the surgeon clinically diagnose this in the acute setting, even if the swelling makes imaging difficult?
The hallmark test is the Lachman test. That assesses the anterior translation of the tibia on the femur, typically performed in 20 to 30 degrees of flexion. The other key test is the pivot shift test.
Which is a bit harder to do.
It's more sensitive to rotational instability, but it requires muscle relaxation, so you often need anesthesia to perform it reliably. A positive result on either suggests a very high probability of rupture.
Regarding management, why the caution on immediate surgery? Why not go in right away?
Initial management is non-operative. RSE, bracing, and physical therapy to reduce swelling and restore motion. Surgical reconstruction is not an emergency. In fact, operating too early, while the knee is still acutely swollen and stiff, carries a very high risk of postoperative arthrofibrosis.
So scarring and permanent stiffness.
Exactly. Therefore, the critical note on timing is to wait until the acute phase subsides and the patient has achieved a full range of motion before you even consider reconstruction.
We briefly mentioned extensor mechanism rupture, the quadriceps or patellar tendons. These must be managed with extreme speed.
Absolutely. These are high-energy injuries, although they can occur in low-energy settings and those with systemic disease or steroid use, which compromises tendon integrity. The clinical finding is unmistakable: severe pain, a palpable gap in the tendon, and the absolute inability to actively extend the knee against gravity.
So you have to operate.
They require prompt surgical repair, usually within days, to prevent the tendon ends from retracting and scarring, which makes a later reconstruction significantly harder.
That brings us to articular cartilage injury. We talked about how hyaline cartilage is avascular and aneral, limiting its repair capacity. Let's expand on the mechanisms of surgical repair, differentiating the approaches for full-thickness defects.
Right. Since partial thickness defects have no blood supply and won't heal, we focus on full-thickness defects, those that penetrate down to the subchondral bone. This injury triggers a response from the bone marrow, potentially forming a reparative clot.
And that leads to the simplest repair technique, microfracture. How does that work?
Microfracture is simple and low cost. The surgeon creates small holes in the subchondral bone, allowing blood and stem cells to seep out of the bone marrow and form a clot over the defect. The issue is that this clot typically matures into fibrocartilage.
Not the good stuff.
It's mechanically inferior to the native hyaline cartilage, and it breaks down over time. It's generally reserved for smaller defects, usually under 2 centimeters square, and in younger patients.
And what if the defect is larger or in a high-load area? That's where the transplant techniques come in.
For larger critical defects, we move to transfer or implantation. You have osteochondral autograft transfer, or OTS, also called mosaicplasty. This involves taking small plugs of healthy bone and cartilage from a non-weight-bearing part of the knee and implanting them into the defect.
So you're patching it with the real thing.
You are. This is hyaline cartilage, so it's a good mechanical repair, but it is limited by the amount of donor tissue available.
And the high-tech option, autologous chondrocyte implantation, ACI, or matrix-assisted ACI, MACI.
These are advanced stage procedures. The surgeon first harvests healthy chondrocytes, the cartilage cells, from the patient. These cells are then sent to a lab to be cultured and multiplied over several weeks. In the second stage, these expanded cells are implanted back into the defect, either under a membrane or mixed into a scaffold.
And the goal there.
The hope is that these cells will regenerate near-native hyaline cartilage, offering superior durability, but it requires highly specialized centers and a much longer recovery time.
Now, the most prevalent degenerative issue, osteoarthritis, OA. It affects a huge percentage of the population over 60. We divide it into primary and secondary.
Primary OA is the idiopathic form, often linked to genetics, age, and systemic factors. Secondary OA is crucial because it has a direct, identifiable cause, often post-traumatic.
Like a previous ACL tear.
Previous ACL or meniscal injury, intra-articular fractures, or prolonged mechanical malalignment. In these cases, the wear is accelerated by the prior insult, confirming the knee's susceptibility to damage once its native stability is compromised.
What are the key clinical features that make us suspect symptomatic knee OA?
Patients typically present with localized pain, stiffness, and swelling. We need to listen carefully to the description of the pain. It's characteristically worse with loading, activity, and weight bearing. A significant clinical feature is that startup stiffness.
The morning stiffness.
Severe stiffness first thing in the morning or after prolonged rest, which slowly improves with movement.
And for pain, specifically localized to the patellofemoral compartment.
That has a very specific hallmark. Pain is typically worse on stairs, especially going down, or when rising from a deep-seated position. That's what places maximum load on that anterior pulley system we discussed. As the disease progresses, the pain moves from intermittent flare-ups to constant severe pain that impacts sleep, severely limits walking distance, and drastically reduces quality of life.
During the physical examination, the gait pattern is key, isn't it?
It is. We look for an antalgic gait or a limp, where the patient adopts a shortened stance phase on the painful limb. They instinctively shift their center of gravity away from the painful joint to minimize the load.
And deformity?
We also assess for deformity, which is usually varus or bow-legged, associated with medial compartment bone loss. Less commonly, we see valgus or knock-knee deformity, often associated with rheumatoid arthritis or lateral compartment collapse. We check for effusion, restricted movement, and audible crepitus, that crunching sound of bone rubbing on bone.
Investigation relies heavily on imaging, but the source stressed a crucial technical requirement for X-rays that is often overlooked.
This is fundamental. Radiographs must be performed weight-bearing, often in both post-row anterior and lateral views. Non-weight-bearing views can obscure the true extent of cartilage loss because the joint space appears falsely widened when the patient is lying down.
You can't see the problem unless there's a load on it.
Exactly. Only a loaded X-ray will reveal the accurate extent of joint space narrowing, which is the primary radiographic indicator of OA. We also look for subchondral sclerosis, osteophytes or bone spurs, and subchondral cysts.
So once the diagnosis is confirmed, what is the mandatory first line of treatment before considering anything surgical?
Non-operative management is the foundation, and it involves 3 pillars. First, activity modification and weight loss, which directly reduce the 4- to 6-fold increase in load across the joint. Second, maintaining strength and motion through targeted exercise and physiotherapy. And third, pharmacological management, typically anti-inflammatories or simple analgesics.
And things like braces.
We can also use walking aids or specialized offloader braces, which physically shift the mechanical axis to the less involved compartment.
There was also a specific caution regarding intra-articular steroid injections?
Yes. They're useful for settling an acute, painful flare-up due to their potent anti-inflammatory effect. However, the source strongly cautions against their long-term or frequent use. Concerns include a low but real risk of introducing infection and, perhaps more significantly, the potential for contributing to further breakdown or damage to the remaining articular cartilage over time.
So they're a Band-Aid, not a cure.
They are a tool for crisis management, not chronic management.
If conservative management fails for degeneration, or if the pathology is acute, we move to surgery. Part 3 is about the different surgical pathways, starting with arthroscopy, the keyhole approach. The indications here are very broad, covering almost all soft tissue problems.
Arthroscopy is the workhorse of knee surgery. It allows for definitive diagnosis and treatment, often as a day case. If we look at the source's indications, we see meniscal work, both repair and debridement cartilage procedures like microfracture and ACI, ligament reconstruction, and addressing mechanical issues like loose body removal.
What about its role in managing acute infection or fractures?
It is indispensable for septic arthritis. We use it to thoroughly wash out the joint, removing pus and inflammatory debris, which is critical to preserving cartilage. It also plays a key role in trauma, particularly tibial plateau fractures.
How so?
It allows the surgeon to visualize the joint surface while reducing the fracture fragments, ensuring a perfect anatomical alignment that might not be possible with plain fluoroscopy.
Let's look back at meniscal surgery now that we are talking about the technical aspects. We agreed repair is the goal for the vascular outer zone. How does the surgeon choose the technical method for fixation inside out versus all inside devices?
The primary methods are inside out or outside in, which use sutures passed across the tear and tied down on the capsule outside the joint. This requires a small incision to protect the surrounding neurovascular structures,
Like the nerves and vessels.
specifically the saphenous nerve and the popliteal artery. The newer all-inside devices use specialized biodegradable implants that allow the surgeon to fix the tear entirely from within the joint capsule. The choice often comes down to the location of the tear and the proximity to those critical structures.
And that post-operative protection for a repair, that's a huge commitment, right?
It requires patient compliance and a lot of patience. We are protecting a healing biological process. A repaired meniscus must be protected from high shear and compression forces, typically necessitating restricted weight bearing, often non-weight bearing for 6 weeks and sometimes up to 3 months, combined with restricted motion in a brace.
A huge contrast with the simple debridement.
A sharp contrast where weight bearing is often immediate.
In moving to cruciate reconstruction, so ACL, what are the practical differences between the two main autograft options? Bone patellar tendon bone, or BTB, versus a 4-strand hamstring?
The BTB graft is strong and allows for rapid bone-to-bone healing at the tunnel site, which can allow for a faster return to light activity. However, it is associated with a higher risk of anterior knee pain and potential issues at the harvest site of the patellar tendon.
And the hamstring?
The hamstring autograft is highly popular because it minimizes those anterior knee pain issues, but its fixation relies on soft tissue healing to the bone tunnel, which can be slower.
The recovery time here is a massive point for athletes.
Absolutely. The average time for return to pivoting sports is up to a year. This period is dictated by the biological process of ligamentization, the graft transforming into a functional ligament, and the required strengthening provided by a meticulous rehabilitation program. Success hinges entirely on that rehab.
We discuss complications, and the source flagged a technical error as the most common issue. Let's elaborate on incorrect tunnel placement.
This is a surgical precision issue. The tunnels, particularly the femoral tunnel, must be placed accurately to recreate the native isometry of the ACL.
Meaning the length of the graft should stay constant.
It should remain relatively constant throughout the range of motion. If the femoral tunnel is placed too far anteriorly, the graft becomes tight in flexion.
And what's the immediate consequence of that anterior misplacement?
It acts as a mechanical block, preventing the patient from achieving full, comfortable knee flexion. Conversely, if placed too posteriorly, the graft might stretch and loosen prematurely, failing to provide the necessary stability. This confirms that surgical success is as much about technique and geometry as it is about the biology of the graft.
And it still might not work perfectly.
Despite best efforts, the source notes a persistent re-rupture rate of approximately 1% per year.
Now, let's talk about this structural intervention designed to change the mechanics of the entire limb. Osteotomy, let's use that analogy. This is a way to re-engineer the load-bearing capacity of the leg.
That's a perfect way to describe it. Osteotomy literally means cutting the bone. The purpose is not to replace the joint surface, but to redistribute the load. If the patient has painful arthritis confined to one compartment, say the medial side causing a varus deformity, we cut the tibia or femur and angle it.
To shift the weight over.
To shift the mechanical axis away from the damaged compartment and onto the healthy compartment. This dramatically reduces pain and delays the need for a replacement.
What's the most common procedure and the mechanism of correction?
The high tibial osteotomy, or HTO, is the most common, performed for a varus knee. To shift the load laterally, we either perform an opening wedge HTO on the medial side or a closing wedge on the lateral side.
And what's more common now?
Modern techniques overwhelmingly favor the opening wedge HTO. The surgeon cuts the bone, opens a wedge, fills it with the bone graft, and secures it with a plate and locking screws. This technique allows for stable fixation and usually early mobilization.
Who is the ideal candidate profile for this demanding procedure versus simply moving straight to a replacement?
The ideal candidate must be young, typically under 60 active, and highly motivated because the recovery and commitment are substantial. Crucially, the degenerative disease must be strictly limited to only one compartment. HTO is a sacrifice procedure. It's demanding, but it buys the patient perhaps 10 to 15 years before the inevitable need for a TKR.
That sets the stage for arthroplasty, the replacement. We must distinguish between unicompartmental, or partial, and total replacement. Given that 20% to 50% of OA is isolated to a single compartment, this decision matrix is crucial.
The rule is pretty clear. If the disease involves all 3 compartments, medial, lateral, and patellofemoral, a total knee replacement, a TKR, is necessary. If the disease is strictly and functionally limited to only one compartment, the patient becomes a candidate for a unicompartmental knee replacement, a UKR.
Let's start with the UKR, which offers some compelling functional advantages.
The UKR, often called a partial knee replacement, is a highly effective procedure if selection criteria are met. The disease is isolated, the ligaments, especially the ACL, are intact, and the fixed deformity is minimal.
And the benefit.
The functional benefits are significant. Complication rates are cited as 1/3 to 1/2 lower than TKR. Patients experience faster recovery, shorter hospital stays, and perhaps most importantly, UKR preserves the native knee kinematics, that rolling and sliding, leading to subjective superior function and a more normal-feeling knee.
Now, let's address the elephant in the room regarding UKR, the long-term revision rate, which is often cited as a weakness compared to TKR.
This is a statistical reality highlighted by national joint registries. While an excellent surgeon can achieve TKR-level survivorship, nationally, UKRs have a higher 10-year revision rate, around 6 to 12%, compared to the standard TKR at 2 to 6%.
So it's a trade-off.
This disparity underscores the statistical trade-off and highlights the absolute necessity of rigorous patient selection and high surgeon experience. This procedure is highly sensitive to the learning curve.
Now, the total knee replacement, TKR, the source calls it one of the most successful surgical interventions in history.
It truly is. TKR is fundamentally a resurfacing procedure. We replace the distal femoral surface with a metal component, and the tibial plateau is addressed with a metal base plate topped by a durable polyethylene insert. The success is defined by pain relief and improved mobility, with phenomenal survivorship. Revision rates are typically less than 5% at 15 years.
Yet, despite those stellar objective results, you noted an interesting detail about patient satisfaction.
Yes. Objectively, TKR is outstanding. Subjectively, however, patient satisfaction is generally lower than that achieved with total hip replacement.
Why is that?
This is almost certainly due to the impossibility of perfectly recreating the natural, complex kinematics of the knee, that combination of rolling, sliding, and rotation, with current implant technology. The hip, being a simple ball and socket, is just easier to replicate.
Let's delve into TKR technical details, fixation and implant design.
Most primary TKR implants utilize cemented fixation using PMMA. The cement provides immediate stability. Design-wise, we categorize implants based on constraint. The most common designs are unconstrained, which either retain the patient's PCL, that's cruciate retaining, or CR, or rely on a box mechanism to replace the PCL function posterior stabilized, or PS.
And when do we move to the more constrained or hinged designs?
We move up the constraint ladder, semi-constrained, fully constrained, or hinged, as the complexity of the pathology increases. Since increased constraint places higher stress on the implant bone interfaces, increasing the risk of mechanical loosening, these are generally reserved for revision surgery, joints with severe bone loss, or highly unstable knees lacking functional ligament support.
What about modern advances in materials designed to combat that long-term enemy?
Advances are focused almost entirely on the polyethylene bearing surface. We now use enhanced, highly durable polymers, like cross-link polyethylene or vitamin E-enriched polyethylene, which are designed to significantly reduce the generation of microscopic wear debris, thereby combating the primary long-term failure mechanism.
Let's discuss the evolution of surgical philosophy. You mentioned the traditional reliance on the mechanical axis. How is that changing now?
Traditionally, the surgical mandate was strict alignment. Ensure the limb was aligned exactly to the mechanical axis, aiming for a perfectly neutral 0-degree varus valgus alignment. This was thought to maximize implant longevity.
But that's not how everyone is built.
We now recognize that many patients naturally have a slightly varus or slightly valgus alignment that is functional for them.
So the shift is toward personalized alignment.
Exactly. The modern philosophy, often called kinematic alignment, attempts to match the patient's individual pre-arthritic alignment, hoping to restore a more natural feel and ultimately improve that elusive patient satisfaction score. To achieve this necessary individualized accuracy, many surgeons now rely on advanced technology like computer navigation or robotics.
TKR is successful, but it is not without risk. Let's review the broad categories of TKR complications, starting in the operating theater.
Intraoperative risks, according to the source, include technical errors like component malposition or malalignment, which we know can lead to early failure. There's the general surgical risk of nerve or vessel injury, iatrogenic fracture, or even rare but serious events like fat embolism.
Postoperatively, the major concerns shift to biological and mechanical failures.
The major postoperative complications include thromboembolic events, DVT, and PE, which are mitigated by prophylaxis. Crucially, there is infection, which can be catastrophic, and then there are mechanical and functional issues. persistent pain or stiffness, instability, and long-term failure mechanisms like aseptic loosening.
Let's focus on that long-term failure mechanism, aseptic loosening. This is what necessitates revision TKR. We need to explain the term polyethylene-induced osteolysis.
Aseptic loosening is the most common cause of late failure, typically occurring after 10 years. The mechanism, osteolysis, is a specific inflammatory reaction. Over time, the polyethylene-bearing surface wears down, generating microscopic plastic debris. The body's immune system recognizes this debris as a foreign body.
And what happens next?
Macrophages, the scavenger cells, attempt to engulf the debris. This cellular activation leads to the release of inflammatory mediators and cytokines, which in turn stimulate cells called osteoclasts.
And osteoclasts eat bone.
These are the very cells responsible for dissolving bone. Thus, the body literally begins to resorb the bones surrounding the implant, causing the component to lose its stable fixation and loosen, requiring revision.
When approaching a failed TKR, the source stresses the absolute mandatory first step.
You must always exclude infection. Always. Even if the signs aren't obvious, infection dramatically compromises the outcome. If infection is confirmed, the standard protocol is a two-stage procedure.
Tell us about that.
First, removing all the infected components, performing aggressive debridement, and inserting an antibiotic-loaded cement spacer. After a period of months for infection clearance, the patient returns for the second stage, reimplantation of a new, definitive TKR. This two-stage approach carries a higher morbidity, but it is necessary to achieve infection eradication.
We established that primary TKR is highly successful. What are the survival statistics for the more complex revision TKR?
They are slightly less robust, which is expected due to the technical difficulty. Revision TKR involves correcting bone loss, using more expensive, complex, and constrained implants, and naturally carries a higher complication rate than the primary procedure. However, the survival rates are still strong, cited at approximately 82% over 20 years.
Finally, let's mention the salvage procedure, knee arthrodesis or fusion.
Arthrodesis is indeed a salvage procedure. It involves surgically fusing the tibia and femur together to eliminate the joint, relieving pain by eliminating motion. It's now rare, reserved for situations where multiple revisions have failed, or in cases of intractable infection where a replacement is no longer viable.
And are there other indications?
It's also used as a primary intervention for patients who lack the muscle control, such as those with Charcot-arthropathy or specific neurological disorders that would otherwise be necessary to manage a mobile knee replacement.
And the specific surgical position for that fusion?
The goal is optimal alignment for walking with minimal limb discrepancy. The ideal fusion position is 7 degrees of valgus and 15 degrees of flexion.
So we've taken a journey from the minute complexities of the meniscal hoop stress and the differential tension in the ACL bundles to the massive, life-altering procedures of arthroplasty.
We really have. We reinforced that the knee's unique kinematics, the rolling, sliding, and inherent rotation, must be respected in both clinical assessment and surgical planning.
And we connected that demanding anatomy to the hard clinical evidence. The medial meniscus is statistically more prone to injury. The patella is a pulley that handles up to 20 times body weight. And the critical need to set the valgus cut angle between 5 and 7 degrees to align a TKR to the true mechanical axis.
Crucially, we differentiated the treatment pathways for degeneration. The highly specialized UKR, which offers superior kinematics but requires perfect patient selection due to its higher national revision rate, versus the robust TKR, which offers phenomenal survivorship but still struggles with patient satisfaction.
Largely due to the inability to perfectly replicate nature.
Exactly. And the key threat to long-term TKR survival remains polyethylene wear leading to osteolysis, the body dissolving the bone around the implant.
The knowledge distilled here, from the criteria for meniscal repair and the vascular zone to the technical challenges of revision surgery, is essential for your revision and practice. You now have the in-depth context to understand not just what the procedures are, but why they are performed the way they are.
And this leads us to our final provocative thought for you to consider. Given the natural instability of the knee and the massive loads it bears, we established that the orthopedic field is moving away from strict universal mechanical alignment toward more personalized kinematic alignment using sophisticated technology. The hope is that this shift will finally boost patient satisfaction to match the excellent objective outcomes we see in hip replacement. But the fundamental mechanical failure remains polyethylene-induced osteolysis. Therefore, the question is, what breakthrough in material science or what non-wearing bearing surface will finally eliminate microscopic plastic debris, pushing the 20-year survival rate of TKR from the high 80s to a reliable 100%?
A huge amount of knowledge unpacked. Mission accomplished. Thank you for joining us for this deep dive.